Hi everybody, welcome to this EFIC webinar. I'm Mary and I'll be your host today. Today we're discussing the ever interesting topic of placebo and nocebo effects, and we're going to cover a good few things. So basic definitions, like a 101 of concepts and terms in the field, mechanisms, causes of these effects, sizes of these effects, clinical importance. So this is sometimes a controversial area. How big is the placebo effect? Misconceptions, ethical issues, and most importantly, clinical implications. So what can we tell our patients? How can we harness placebo effects, reduce nocebo, receive more education? And I'll be briefly discussing a higher education project called Panacea at the end, which EFIC is delighted to be a partner in, that you should follow to keep up with more information and receive maybe more training in this issue. So to do this, I'm joined by three wonderful speakers and researchers on this topic. I think Stefanie has joined, I'm not sure, but I think she's here now. So we have Przemyslaw Babel from Poland. Welcome, Przemyslaw, thanks for joining. We've Stefanie Meeuwis from the Netherlands, and we've David Hohenschurz-Schmidt from the UK. So all three will introduce themselves and their interests to begin with. Then I'll ask some questions to guide the discussion. But what would be really great is if you in the audience can post some questions in the chat at any time. It could be now, it could be later on, and I'll ask the questions as we go along. So, Przemyslaw, do you want to start off by introducing yourself? Tell us who you are, what you do, and then we can move on to Stefanie and David. Thanks.
Yes, sure. Thank you. Thank you for inviting me and for organizing this webinar. I'm happy to see all of you. And I'm a psychologist working at the Jagiellonian University, where I had the pain research group. And our main focus are learning mechanisms of placebo effects. So we do studies on classical conditioning, verbal suggestions, observational learning, and recently more into operant conditioning. And we are looking for their role in both induction of placebo and nocebo effects, but also on their role on reversal of nocebo effects. We are recently focusing on the reversal procedures. So yes, I think it's this is the main line of our research. Thank you.
Super. So we'll get into the specifics of that later. And David?
Hi, thank you for inviting me. It's a real pleasure, and thanks everyone for attending. I hope we have an interesting discussion here. I've got a clinical background as a manuotherapist, an osteopath specifically, trained in the UK. I've worked a few years in clinical practice, and then went into pain research through an MSc in neuroscience and a PhD at a pain research group at Imperial College. And that was still very much focused on non-pharmacological interventions. So one of the big questions was, what is a good clinical trial design for physical and psychological therapies? One of the big challenges there being, how do you produce the equivalent of a placebo pill-controlled trial that you have in drug research, where that principle is pretty straightforward? How do you replicate that or achieve this kind of controlling for placebo effects and expectations in more complex and interactive interventions? And that was really what got me into the study of the placebo effect, which we mainly did through some systematic reviews. So research on research, if you will. And at the moment I'm working on a more clinically focused project with people with painful diabetic neuropathy. Yeah.
Excellent. Thanks, David. And Stefanie?
Yeah, so thanks for inviting me. It's a really pleasure to be here. So I'm working in the Netherlands, in Leiden. I have background in psychology, and I'm currently a postdoctoral researcher here. And mainly, so my work mainly focuses on placebo and nocebo effects in somatic symptoms. So not just pain, but more like in a broad sense. So also itch and other symptoms. And we do some basic mechanism studies, so also looking into how expectations and learning can influence pain and other symptoms, but also more clinically applied research. So really figuring out, like, how can we use these effects in the clinical practice. So.
Excellent. And yeah, we'll definitely be getting into the clinical practice side of it. Okay, so if we just start the audience off with a 101 on terminology, because there's so many words, labels floating around, new ones coming up. So it'd be good to start there and get some clarity. So we'll start with, what is the placebo effect? You can all, who wants to begin?
Open audience. I think I might start with saying what it is not. And
okay.
The important distinction to draw there is that people can get better from various mechanisms and sources. So if you imagine you've got low back pain, we all know, or well, those who have had it know that it often comes in phases or in episodes. So it tends to get better, even though it might get worse again at some point. So there's getting better from the natural history of a condition and a disease. If you study that in clinical trials, most people sign up to a study when they are in a pretty bad state, so they will get better just through a passage of time. Then you've got statistical phenomena, which are called regression phenomena, where taking observations at 2 time points will mean you have some benefit there as well. So these are things that can get confused with the placebo effect, which I'll leave someone else to define now.
That was really helpful though, because that is a common misconception. Okay, who wants to jump in? Stefanie, go for it.
Yeah, I can pitch in. Yeah, so like David said, there are a lot of non-specific effects which can be confused with placebo effects. But I think the core of placebo effects is that it's caused by expectations, and these expectations can be derived from the context. So basically any information about the treatment which can cause an expectation, or which people have experience with previously, because learning is also one of these mechanisms of placebo effects. So any expectation that can about becoming better, I think this is the specific distinction, and the thing that we say, like this is really a placebo effect if it's caused by the expectations.
So when people say you get the pain relief you expect, you know, some people say that,
Yeah.
is that kind of bound up with this belief that if you think you're going to get better, or you have beliefs around the treatment, that it influences that?
Yeah, that's basically it's a bit more complicated, of course, but we will get into that later, I guess. Yeah.
What about a placebo treatment? So when someone says, "Oh, this treatment is a placebo," or somebody did a placebo randomized trial, is that a different thing than to the placebo effect? Are these different concepts? I'm just doing this for the audience, like really picking apart these words.
Okay.
Do you want to do that, Przemyslaw?
I can do it. You can, or you can. Yeah, do you want me to say something? Yeah. So there are, like, I would say that there are two broad perspectives. One is narrow, actually, that when we look at the placebo effects, are the effects of some inert interventions. So, you know, sugar pills, or I don't know, surgeries, shame surgeries or something. So there is if there is some intervention and it's inert, then we speak about placebo effects, if of course they work. But also the broader perspective is that every factors that actually have an effect on disease, on health, so like even if we use active medication, so the shape, color of the tablet, or the, you know, some factors concerning the place where the treatment is organized, you know, the how the
Have we lost a bit of sound there, or is it just on my side?
No, here as well.
Yeah, same.
Okay, so hopefully his sound gets back soon. So another question with the placebo effect is the mention of non-specific effects. Is a non-specific effect always a placebo or nocebo effect? Or can they be different?
I think it can be different. Like David mentioned, like there are a lot of non-specific effects, and people, for instance, they tend to sign up to studies when they have a lot of complaints. We have the natural regression to the mean over time. Also the natural cause of the disease, because that fluctuates over time, and this is also a non-specific effect. And yeah, the effects of other interventions. For instance, people, if they participate in a study, they tend to want to change something, and they can also make other changes to their lives, for instance, to their lifestyle, which can also affect their symptoms. And this is, I think you would say this is a non-specific effect when you talk about the effects in the study, but it's not a placebo effect per se.
Good. That's very helpful.
I think we can add to that by saying it can sort of in a clinical context sometimes become a question of definitions and of perspectives. So if you look at a complex intervention like surgery, or going to see a psychologist, or even doing a yoga class, and in manuotherapy, that's certainly a big issue. We don't quite know how some of that actually works, but we all know it works through more than one mechanism. So that's what you would often call then the specific effect. And in a study, you have to define which of those effects you're trying to study, and everything else then suddenly becomes non-specific. But when you go in clinical practice, nobody would say that, you know, a good relationship to a patient, or providing some education and advice or reassurance on the side, is unimportant, which unspecific might kind of suggest. So it's really a term from the research world that can become a little bit less helpful in a clinical context. And I think we can go even further than that and say the placebo term itself is quite negatively connoted. When you go back to your previous question, you know, if someone says, "Oh, that's just a placebo," that's quite a negative statement usually, or perceived as quite negative. And hopefully maybe here in this webinar, we can turn around a little bit and say, oh, the placebo effect are learning and expectation effects. And in clinical practice, we can work with those. We should be aware of them. And also if they're counter, we'll get into in a second, I think.
Yeah, I think that's really cool, because when I first learned about placebo, I would have seen it as a negative thing, that when someone says that treatment is a placebo, it's like, oh, it doesn't really have any effect. It's just something else. So yeah, hopefully we can dispel some of that. One more label that's with placebo is this new, well, it's not new, but new to some of us, is open label placebo. If we get a definition of that as well before we get into more discussion, that would be good. Who wants to define that? Przemyslaw, do you want to define open label placebo? You had a really good editorial on it recently.
Oh, I can, but Stefanie is an expert here. So I can only say that open label placebo is when we honestly inform participants or patients that what they receive is actually a placebo. And it works, and and there is a lot of data showing that it works not worse than deceptive placebo when they are not informed. But there is one tricky information, very important here, that they don't only receive an information that this is placebo, but they also receive very strong suggestion that placebo is working, why it's working, what are the mechanisms of open label placebo. What are the studies showing there? Actually, when we use open label placebo, we give much more suggestion to patients than when we use deceptive placebo, because when we use deceptive placebo, we just say, okay, this is something very effective, especially, for example, for your pain. But when we use open label placebo, we elaborate more why something that has no actually pharmacological potential, pharmacologically active substance, how it can induce these effects. However, and there are also some studies showing that even if people are just informed, this is placebo, it still works. I know at least 2 or 3 studies in which actually people from control groups with placebos, they were told that this is placebo and you are in a control group, and they had some effects. And of course, these effects were stronger than the effects in natural history groups. So actually it was placebo, but usually we need much more information to induce placebo effects when it's open label.
Okay, great. So we have a definition. We'll come back to that again about the effects of open label, because yeah, that's interesting. Now, if we have a definition of nocebo effect, so we have placebo effect, we have placebo treatment, we've non-specific defined, we've open label placebo. Now, nocebo effect, if we get a definition of that before we move forward.
I think nocebo effect, you can define it as pretty much the opposite of the placebo effect. So basically, this is when you expect something negative from a treatment, and this can be anything. Like it could be an expectation that a treatment doesn't work, but it could also be an expectation of side effects. So if you're afraid that you will get a lot of side effects, these expectations again can lead to these nocebo effects. So nocebo effect is a negative treatment outcome or a less successful treatment outcome. I think you get like these 2 different types of nocebo effects, I would say.
Okay. And we have 2 terms, placebo hypoalgesia. That means when a placebo effect reduces someone's pain. Is that correct?
Yes.
And nocebo hyperalgesia is when a nocebo effect increases somebody's pain.
Yeah, that's correct. Yeah.
Okay. So, okay, we've done a little tour of terminology there. If anyone in the audience has any other terms they want to find, please post them in the chat. I have some true or false questions here that I've just made up. I want the answers to that people might find interesting. So how a clinician looks influences the patient outcome. Is just true or false. So it could be the look that they can't modify, just how they look as a person, but also their clothes. Is this true or false, that it affects outcome?
I think this might be a difficult one to ask. All of these are, there are some studies that suggest that it might be the case, and some where you look at big groups or averages where you might not find something. And then you go into clinical practice, and you certainly have situations where it's quite easy to envision how 2 people might not get along. There's a lot of studies on sort of interracial encounters as well, where other prejudice and bias plays in as well, with regards to better or worse clinical outcomes. And then there are factors like patient adherence, whether they actually continue seeking a therapy or not, if they don't get on well with somebody. Then there are preferences. Some people might want to see someone who comes across as godlike, knowledgeable, and others probably feel more confident or comfortable with an encounter at eye level. So I don't want to give a straightforward answer to that question.
Okay. What about the age of the clinician? Because when I remember when I graduated and when I was qualified as a physio, and fully qualified, slightly competent, I guess, I might have patients come to me and say, "Oh, I'm here to see the physio. Are you a student, or when are you graduating?" And I was like, "No, I'm your physio." And there is this moment, that how I looked, because I looked younger, I somehow maybe wasn't taken as seriously. Is there anything in the literature on this, or was it my imagination? Stefanie, do you have anything to say?
I'm not sure actually if anyone has looked at age specifically, but I do know that there are some studies that look at confidence and like general demeanor of clinicians. And I think there they do find some effects. And yeah, I mean, I could imagine that age could also play a factor here, but I'm not aware of any studies that really look into that. I don't know if anyone else is.
No, I'm ignoring the topic age at the moment. Just telling myself it's not a problem.
But I think this is a very good question, because it can the answer can illustrate what actually is going on in the placebo studies field. Because we have a lot of data, but we also have some, books, some advices showing that, for example, the credibility of the practitioner is very important, a white coat, stethoscope, and so on. But actually, there is not much data on it. It's like, based on what we know, that the contextual cues work. People say that you should look credible, whatever it means. But I wouldn't say that it's like evidence-based. It's like based on evidence, but no then investigated whether it really works.
Okay, we might talk about that later on if maybe people are interested in looking, how do you look more credible, for example. Okay, good. And another one is placebo is all in the mind. Is this true or false?
I would say false. Like a lot of studies show that you really have these changes, not just like psychological, but like really physiological changes, and also the mechanisms. There are a lot of imaging studies that show that really like the brain response changes due to placebo. And so it's not just in the mind, I would say.
Excellent, and that'll lead us into, we're going to talk about mechanisms there in a second, but we have really good questions coming in the chat, keep them coming. But I've one that in the true or false, I'm going to ask it now. What about the environment? So the environment, whether your practice has free parking or not, does that have an influence on some outcome? It could be satisfaction, pain, quality of life. Maybe we don't have the literature in particular. It's a good question. Any thoughts on that? Thanks for the question.
I think environment's generally one that's a bit better studied compared to age, for example. So it does come up regularly in summaries of what might have an effect. I don't know about free parking, but certainly alongside the impression of professionalism and coming into a healing environment and is certainly important. And if you think back to some of the other maybe less evidence-based healing practices, humans have always they always occur in a certain environment and with a certain ritual, which speaks to the notion that you want something extraordinary out of the normal, which signals that this is where healing happens, whether that's a church, a particular cave, or a particular treatment environment. That probably doesn't matter, but it seems we're quite susceptible to that.
Okay. That's very interesting. Okay, so if we move on to mechanisms, so we're a bit more comfortable with terminology now, I think. What do we know about the mechanisms involved first in the placebo effect? So in your backgrounds, you've mentioned, learning, classical conditioning, operant conditioning. Could we, all three of you, maybe one by one, speak about what mechanisms do we know to be involved? Stefanie, you mentioned, the brain. What's causing these effects, or what underlies them in the body and mind?
Seems like, I'm now, okay. Sorry, I have like problems with connection. Should I answer your question now?
Yeah, do you want to start, and you can speak about maybe observational learning and your conditioning work? I think that's very interesting for the audience. Okay, so I would say first that generally placebo effects are seen as learning phenomena, and different types of learning procedures, like I said at the very beginning, for example, verbal suggestion, because it's also kind of learning by words, classical conditioning, and so on, they induce placebo or nocebo effects. However, the question is in the field now whether these are the mechanisms, or actually the mechanisms are expectations, as Stefanie said at the very beginning. So because learning processes can induce placebo effects without, for example, involvement of expectations,
but in most cases, actually, they induce changes in expectations. So, for example, with observational learning, when we observe somebody in pain who get a pill, the pill works for him. We observe that the pill is effective. So then when we take a pill, which can be placebo, for example, and this pill works because we saw somebody for whom it worked, regardless of whether it was active or not. When we got placebo after we saw somebody with the same tablet or looking like the same tablet, it should be working. And the question then is whether observational learning is a mechanism of this effect, or whether expectations actually change. So we saw somebody, and then it changed our expectations. We thought, wow, this might be working for me also. And then we took the pill. And the funny thing is that we, last year, together with Stefanie was leading this project, we published a systematic review on all the studies on observational learning, and of course, in the context of placebo and pain. And we didn't find actually evidence for expectations mediation. But this was mainly because most of the studies didn't check for expectations. So actually, this is something we still don't have data. However, based on the theory, we could say that when you observe somebody, it is really probable that it changes your expectations. What we know from classical conditioning is that this process can work on a very low level. So that there are cases also from our studies, but not only from our studies, showing that you can induce placebo and nocebo effects by classical conditioning without not only mediation of expectations, but also without any awareness of participants. These effects are, of course, not very big. They are actually small, but still significant. And so I believe that mostly the learning processes induces placebo effects. However, they work either by changing expectations or without it. So we can say that the question of the mechanism is still to be resolved, and we of course need more data. But generally, learning and expectations are most important mechanisms that are studied now.
Just on terminology, you mentioned conditioning, just for people that might not know a lot about it. Could you define classical conditioning and upper conditioning, what that looks like?
Sure. So with classical conditioning, actually we have something neutral, for example, a pill that is neutral. We don't know how it works, but because it inside of this pill, which is, let's say, round and white, and inside this pill there is a paracetamol, and we experience it working, and then this the way the pill looks, so that is round and white, becomes actually conditioned stimuli, which start working as similar to unconditioned stimulus, so paracetamol. So when we then just take round white tablet without any paracetamol inside, it can work for us because of classical conditioning, because we learned that this stimuli actually induce some changes in us. And very important is that then even if we take this white round tablet with paracetamol inside, it should work better for us, because then paracetamol works, and also the shape, shape, color, and so on also start working. So this is why, for example, if we change the topic from pain to, for example, coffee starts working for us, starting inducing some changes in our body before actually caffeine, that is a part of coffee, is starting working. So at first, what works for us is just the smell and color of coffee, and then the caffeine actually starts. So this is classical conditioning, and with operant conditioning, we actually are rewarded for having experienced placebo effects. So when the medicine placebo starts working for us, It's first, of course, pain relief. It's kind of a reward for us, but also the way that people say, okay, it's working, so it's your body is healing. So all the information coming from medical staff, but also from our, I don't know, people from our family who see changes in us and they say, oh, wow, it's working. Yeah, so these are actually operant conditioning will not probably work just as the only mechanism of placebo effects. It is combined actually with classical conditioning. It's something additional, but we see in recent studies that it's important.
Okay, and how do we see this play out in the brain, for example? Is there, you know, I guess, physical signs of these expectancies having an effect, whether they be negative expectancies or positive expectancies? Stefanie, you mentioned that. Do you want to talk to us a bit about that?
Yes, of course. So basically what, first, I'm not an expert on brain mechanisms, but I do know some, so I will do my best to explain it. So what we see in the brain is that expectations and learning, they can influence the way that pain is processed in the brain. So you have the incoming information from the body, and what you see when people expect active treatment is that the prefrontal cortex becomes involved, and actually you get a sort of top-down control over the pain. So what you see is that the brain areas typically involved in pain processing, they are less responsive when people have received placebo. So, and for nocebo effects, the brain mechanisms are a little bit different, but what you see there is that if people expect this negative event, if they expect more pain, if they've learned before that they are getting something which is quite painful, then the response becomes like higher.
So there are changes we can objectively see in.
Yes.
Okay, great. So the next thing I want to challenge you on is the power of these effects. So, you know, we've spoken a lot about it has an effect on this, has an effect on that. How big are the effects? So when we look at the placebo effect, how large is the effect for, let's say, low back pain or any pain condition? People often debate the magnitude of these effects. You know, are we going, is it a suggestion about beyond the evidence? You know, do we have evidence to say that these are important enough? What would you say to that in terms of the size of the effects? David, I know you've done a good few reviews where you're trying to unpick this issue across pharmacology but non-pharmacological approaches. Do you want to speak a bit to that?
Yeah, it's a really good question, because sometimes I think these effects tend to get overemphasized, maybe. And at the same time, you shouldn't neglect them as well. And I think that's kind of what comes out of the literature. And just to say about how this has been studied, often by putting together various randomized control trials, and ideally trials that have a group that doesn't get any treatment, so or usual care group. And then you compare that to a group that gets either a placebo pill or a physical psychological intervention that's supposed to act as a placebo control. And then you can compare the differences over time between those two groups. We've done that with 17 trials from physical and psychological interventions and found what you typically call a small overall effect. We've also quantified that as a proportion of the overall effect, which is maybe a bit more illustrative, but then obviously it depends really on the efficacy of the interventions that are being studied. If you have a highly efficacious therapy, that proportion might be a bit smaller. And then there were two other systematic reviews coming out almost at the same time, ours and a group from Denmark in the European Journal of Pain, and one from a German group the German group published in European Journal of Pain as well, and the Danish group in Pain. So it's definitely worth looking at those. And they all have slightly different approaches there, but they all come to the conclusion that it's at best a small effect, but that makes up a considerable proportion of overall treatment effects. So I think the takeaway there is that we shouldn't neglect those effects, but at the same time that we are using RCTs and not sort of clinical scenarios necessarily always to study those. And we know that in experimental studies, so when they do those experimentally induced placebo effects, often with healthy volunteers, sometimes the objective there is obviously to maximize placebo effects, which is very different to a clinical trial where you're trying to avoid them in your control arm, because otherwise your treatment looks less efficacious. We know that in those experimental settings, the effects can be much larger. Yeah.
Excellent. So we have some really good questions coming here, all very good. So I'm going to break into them because they cover a lot of what we want to cover anyway. Are we looking into how we monitor the effects of the therapeutic encounter that encompasses non-specific effects, whether they're placebo or nocebo? So this is a measurement question. Any thoughts on that?
I think in especially in the clinical trials and in clinical practice itself, it's very difficult to really differentiate between the non-specific effects. So it's tricky. Like in the experimental studies with the healthy volunteers, we can really we can manipulate the entire encounter, and we can just, change like one small thing, see what it does. But in the clinical practice and in the clinical trials, this is more tricky. Like usually, at least what we try to do in our research group is control for at least a few things. Like when we set up a study to look at the effects of, let's say, an expectancy training, or see how we can use the placebo effects in the clinical practice, we tend to control for at least the attention. So the people that do not get the expectancy training, they do get at least the same amount of attention from a healthcare provider. Also, when we look at placebo education, for example, telling people about placebo effects, we tend to switch out, give some neutral information. But this is always like a balance and a little bit tricky to really clearly differentiate between these effects. Yeah.
Great. Okay, so this is a big topic. Ethics. Is using placebos for the treatment of pain ethical? Lots of discussions recently regarding NICE's guidance on the use of saline injections for the treatment of pain during labor.
Yeah, I've got a few thoughts on that, but there's again no right or wrong. This specific example is interesting because it's made it into guidance, but often it's worth remembering that we've always used and doctors always used things that they didn't necessarily believe had a specific effect in for patients, but would prescribe them as well. Either, trying to do something better than nothing, or to meet patient expectations of receiving some form of treatment. And the first thing there to note, probably from an ethical perspective, is to do no harm. Where maybe that saline injection becomes already a bit more problematic because it is more invasive than taking a supplement that we don't think is efficacious. So there's the consideration of harm involved in doing that. And then there's obviously the consideration of patient autonomy and respect for that. That's probably where open label placebos are advocated for, because they get rid of that problem. You explain and clearly get patients to consent to that, to the application of a placebo. And then there are the scenarios where we don't really know whether a treatment is more efficacious than a placebo intervention. And then it becomes a question of, well, is that worth paying for? Do patients, what level of evidence do patients and policymakers need to provide that? But also, if I'm teaching that particular intervention, say some kind of alternative therapy or manual therapy technique, and the evidence for that is patchy or actually suggests that it doesn't work better than the placebo effect, where does that leave me as an education provider? What do students say when they find out about that? What do patients think about paying for that? So it is a complex field.
Any other comments on that? Przemyslaw or Stefanie, do you have anything to add to that around ethics?
Well, I can only say that there are some studies showing that actually placebo prescription is very popular, so that medical doctors often prescribe placebo or just say take it. And in some cases, they don't know that this is actually a placebo, but in many cases, they actually know it. So this is a real problem. So this is not the problem only of the ethics of clinical trials, which is also important, but this is the ethics of everyday clinical practice. And we know, for example, from our studies, but also from studies from Germany, that homeopathy, which is purely placebo actually, it's very popular, and it's it's prescribed by medical doctors every day. And so I believe that, of course, open label placebo is a very nice alternative for deceptive placebo. But the real problem is that sometimes there are medicines which are actually placebo, but they are prescribed as they were active, and this is something that we should reflect on. And I of course don't have any ideas how to do it. Maybe the guidance, which would be much more popular, when people would know that homeopathy is something that it's actually placebo. I had, for example, it's my personal experience when the vet prescribed for my cat a homeopathic remedium, and I realized it in the pharmacy. And in the pharmacy, they said, okay, I don't want it. It's homeopathy. But they said, yeah, but it's working. I said, yeah, it's working, but this is a cat. So I don't think that that she believes in it. Yeah. So this is. I know that I'm not addressing actually the question, but just want to raise that this is a real problem, and that from different studies, different studies show that from 60 to even 95% of practitioners use placebo, prescribe placebo. And also what before David said, because placebo has this negative connotation, they are not so, when we asked medical doctors whether you prescribe placebo, fewer of them agreed. But if we ask them whether they use non-specific medicines, much more agree. And actually these non-specific medicines are placebos.
Okay. So there's a lot to kind of find out about, a lot to research around how best to ensure all of this is ethically done. Okay, so there's a comment here. It is more a comment than a question, with a question at the end. In clinical practice, there are many factors that impact outcomes, including expectations of something working from previous learning and what they are told. It is difficult to distinguish between placebo, nocebo, and all the other factors that would be classed as non-specific based on what you mentioned earlier, like environment, practicing yoga, and making lifestyle changes. A compassionate, safe space is really important. Does someone being heard and validated come into placebo effect, or would it be non-specific?
I think it definitely comes into play for placebo effects as well, like empathy and the patient-provider relation, and like you mentioned, the safe space for patients is really important for the placebo effect as well, because I think it can amplify these effects. So a good healthcare provider with whom you have a good connection can impact what you expect to happen in the treatment. So yeah, so definitely. I mean, it's not strictly divide, like I don't like to strictly divide it into non-specific and placebo, but I think, yeah, that definitely if you these contextual factors can amplify the placebo effect. Yeah.
Great, and we'll spend the last 10 minutes on what can clinicians do to be better at these things. But there's an interesting question here. Is it possible to predict the susceptibility to placebo, or I guess nocebo, certain demographic factors? Or I guess we could word it different. Is there risk, what risk factors maybe? Systematic reviews and meta-analysis on effect size based on a broad patient population may dilute the effect on certain subgroups. Any comments there? Thanks for the question.
Yeah, really good question. One that the pharma lobby has asked itself for decades, because you can then get rid of placebo responders and make your drugs look more effective. So there's a lot of research into that actually. And the best predictor are expectations. So if you ask people what they expect from the treatment, from the intervention, that is the best predictor, as we've just learned. That's due to the mechanisms underlying that. But you can't always do that, or patients don't, haven't experienced the treatment, or wouldn't know about their expectations necessarily. And then there are things like baseline pain levels, and sometimes features of the drug or the intervention itself that tends to influence outcomes. And we've done a meta-analysis with regression analyses there, where we've showed that sort of more intensity care clearly makes an effect beyond just more treatment effects. Also, it increases the potential for placebo effects. But there it becomes pretty patchy again.
Okay, so when we're wrapping up, clinicians, so we're talking low-hanging fruit. If we take away negative connotations of placebo and clinicians just want to improve their outcomes with the patient, maybe they want to help change patient expectations, they want to use better language. Any advice you would give? We start with maybe expectations and verbal suggestions. What could clinicians do here to get better at things like that?
Well, I think there are a lot of things that clinicians can do, and most of it is can be found in the communication. So the way that you present information about the treatment can affect patient expectations. It's important here because we are talking about positive expectations, and one important thing to mention here is that you need to be realistic. So if you are like overly positive and say like, okay, after this, like everything will be perfectly fine, when it's not, then you can get this expectation violation and people can actually lose trust in the treatment. So that's one important thing to keep in mind. But other than that, the way you present information, so for instance about side effects, a lot of some side effects can be nocebo effects. So if people read the information leaflet, or if they get information from their doctor who tells them like, okay, you get this medication, but you may get a headache, people can start to focus on it or misattribute it. And there are studies that show that if you reframe that information, so if you say like, it can occur, most people do not get it, but this can very much influence the way, like whether nocebo effects occur or not.
What about the language we use around structure? So my background, I'm a low back pain researcher, and in the clinic, we know a lot of people get told scary things, maybe like words like degeneration or bulge, but then it's hard to kind of replace it with maybe a more non-specific description. How could we do this without mentioning those labels, but also making sure the person goes home feeling validated and that their condition hasn't been dismissed. Any thoughts around that?
This is always a little bit of a tricky topic because you do want to explain things to people. I would say I'm not a clinician, but yeah, I would say that explaining really clearly and using tailored information, so information that you know that the person will understand is one of the main things. So try to avoid the really difficult terms if you can. And yeah, I don't know, David, do you want to add something?
Yeah, I might add a little bit. I think a good starting point is to reflect on how we've been trained and the kind of language that we tend to use in clinical practice generally, and maybe put ourselves in the shoes of someone who hasn't been trained in that same way, or who doesn't speak medical jargon, doesn't know that a disc bulge is actually something that often resolves by itself or doesn't always lead to symptoms. And then see whether we can adapt our language to still communicate honestly and clearly, but without the potential for negative expectation creation, or even more broadly, other undesirable effects. Like, you know, if someone tells me my back is out of whack or is broken, or I've got a slipped something vertebra there, even though that's stabilized, I might not hear that second part, and I might think I'm unstable and I shouldn't be doing any exercise anymore, or I definitely need some imaging, or I might be better off getting my back screwed back into place. So these are negative, undesirable effects way beyond negative expectations and hypoalgesia that's often transient. So if anyone's interested in that topic, we've got a paper in Musculoskeletal Science and Practice where we say, well, a lot of us musculoskeletal practitioners in particular have traditionally been trained in those biomechanical, mechanistic models. Maybe we still use them in our head, but do we actually need to communicate them to patients? Or is there a better way to avoid these undesirable effects?
Yeah, so that's a really good paper. I'll share it with the attendees after the webinar. Is there any training that people can receive? So I'm going to talk about the Panacea project that EFIC are involved in, and Przemyslaw and Stefanie are also involved in. But is there any training that a clinician could do now where they're like, oh, I don't really know a lot about placebo effects, nocebo effects. I want to get better at harnessing them or preventing them in the clinic? Any advice for reading? What can people do?
Well, I'm not familiar with any training. There are, of course, books on placebos, and some of them are more popular than the others. So it's I don't have anything in mind now particular, but there are good books, yeah. And if they are wrote by experts and they are like written in popular language, then I believe that would be really important. And what I believe it's really important now. It's that we should translate what we know from basic science into some recommendations. And this is, of course, part of the Panacea project that you have mentioned, but also there are some position papers which show these recommendations, because, you know, sometimes it's not only the recommendation concerning what to do, like with words. Of course, words can heal, they can harm, and we should be very and there can be many suggestions how to use words, and Stefanie nicely showed some of them. But this is also kind of awareness that, for example, previous experience is important. So if your previous, and this is more from classical conditioning studies, that if your therapy failed many times before, so next therapy would, even if very effective, very active, it may not work for you because your previous conditioning actually makes you not be susceptible for the next very good therapy. And this is I remember the one of the most important papers by Ian Vikramasekera, who introduces classical conditioning theory of placebo effects many years ago, like in 1980. And one of his predictions was that actually those medical doctors who use very active, very effective treatment will induce also strong placebo effects. So this may seem paradoxical, but it's not. So actually, if I was given just say one word to clinicians, I would say that please try to use as effective treatment as you can, because then you will use like two sources of effectiveness. One source, which is the active ingredient of the treatment, and another one, they are all the contextual factors which may contribute to placebo effects, and then you will get much more effective treatment. The worst thing you can do is to rely on placebo effects, because placebo effects are strong, but because they are learning phenomena, they of course also extinguish. So you cannot rely only on placebo effects. So the best idea from me would be that do what is recommended, use the treatments that are effective, and then you will get also placebo effects.
Excellent. I'm just going to finish on one last slide that I hope everyone can see. So this is just letting you know a bit about the Panacea project. So it's a higher education project funded by Erasmus+. And this consortium is really interested in bringing what we know in theory and research into practice for clinicians. So if you want to find out more about the project and the training they're developed, I've posted the website in the chat. It's also here. They have a really active Instagram account and Twitter account. So check them out. So I hope everybody enjoyed that. I'd like to thank our speakers. I found that really interesting and learned a lot, particularly around the negative connotations of placebo and the way we need to kind of shift our thinking there. So thanks everyone for joining, and have a good day. Thanks everyone.
Thanks for having us.
Thank you very much. Have a good day. See you.
Thank you. Have a good day.
Bye.